Good afternoon, and welcome to a very warm edition of Health Leaders Winning Edge program, a weekly series of webinars touching on the topics and strategies that you need to know. My name is Eric Wickland, and I'm the Senior Editor for Innovation and Technology here at Health Leaders. I'm going to be your moderator for today's session. Today's webinar is titled The Winning Edge for Moving Forward with the Hospital at Home Strategy, one of my favorite topics. Thank you to you and our audience for attending and participating in today's panel. Before we get started, I do have a few housekeeping details. Our program will be approximately 60 minutes in length. Note that an on-demand version of this program will be available on our YouTube channel this Friday, and it can be accessed through our website, healthleaders.com, healthleadersmedia.com. To ensure that you can see all the content for this event, please maximize your event window and be sure to adjust your computer volume settings and or PC speakers for optimal sound quality. Next, you're going to find a resources list for today's webinar on the upper right of your screen. Here we've listed the webinar slide deck and some additional materials for you to download, along with a registration link for future Winning Edge events. Now, next, at the bottom of your console, we've got multiple widgets that you can use to submit a question, and we will have a Q&A session to this webinar. It'll be the last 10-15 minutes of the event. To submit a question for that Q&A, click on the Q&A widget. It may be open already and appear on the left side of your screen. You can submit questions at any time during this hour. However, please note that it's likely those questions won't be answered until that Q&A session. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which is a question mark icon and covers common technical issues. Now, with that, it's my pleasure to introduce our three panelists for today's very entertaining discussion. We have Logan Davies, Medical Director of Hospital Access and Throughput at Ochsner Health. Daniel Davies, Senior Medical Director for Continuing Health for the North Carolina Georgia Division, and Senior Medical Director of Primary Care for the Greater Charlotte market for Advocate Health. And Stephen Dorner, Chief of Clinical Operations and Medical Affairs for Mass General Brigham's Healthcare at Home program. Thank you, all three of us, for taking part in today's panel. And with that, now I'm going to jump to the first question, and this is a basic question for all of our panels. It's a good way of getting us into the program. I want you to each tell us a little bit about yourselves and your organizations and your hospital at home programs. Let's start with Stephen.
Sure. Eric, thanks for having me and for facilitating this venue for us to talk about all of our favorite topics at the hospital at home. So Mass General Brigham is an integrated academic medical system based in New England, operates a multi-state strategy, but we run our hospital at home out of 5 acute care hospitals in Greater Boston. So that's Mass General Hospital, Brigham Women's Hospital, and then 3 of our affiliated community sites. And we run a 70-bed operation across 72 towns in the Greater Boston area, pulling patients out of each of those 5 participating hospitals, but then caring for them with one centralized, consistent operation. And we provide service to what's about 400 or so patients a month who receive the full complement of what would otherwise be delivered during an inpatient hospital stay at one of those 5 acute hospitals. And that runs a gambit from traditional medical patients who are being admitted for COPD, heart failure, cellulitis, to postpartum hypertension and peri-op conditions as well. Cancer, patients who undergo intra-abdominal bowel surgery, spine surgery, and we're constantly expanding those capabilities across the different service lines. So look forward to talking more about how we built their service and answering questions.
Great, thank you. Logan, what's Ochsner doing with Hospital at Home?
Yeah, thank you. So Ochsner is a 3-state, 60-hospital system with 3 primary academic medical centers as our hubs. Our version of Hospital at Home, called Acute Care at Home, is centered on our New Orleans market, which is our largest AMC and our largest tertiary referral center. We do have 3 linked community hospitals that are also providing the service as well. We are a fairly new entrant into this space. We've had a lot of start and stops. We have done the approach through traditional waiver programs in the past. And when we brought this up out of the dirt, if you will, about a year and a half ago, we decided to go a different direction. First, with our concentration of value-based lives, which we have over 200,000 in the health system, with a lot of them centered on the New Orleans market. And then expansion into all Medicare plans. We currently care for about 250 and rising patients a month. Our velocity of enrollment is rapidly increasing. Our average daily census is somewhere just about 70 or 75. And we've seen a multitude of great outcomes that I think are consistent with the stories of other acute care at home or hospital at home programs in terms of leveling out our utilization and having good patient outcomes. Right now, we really focus on two routes of entry into the program. One is avoiding low acuity admissions from our ED, and then using this kind of as a back end proposition for a hospital stay, generally focused on high readmission reduction, but occasionally we do employ it for length of stay reduction, and that is a horizon that we are marching towards more in scale.
Great. Okay, perfect. Daniel, same question. How's Advocate doing in the hospital home space?
Yes, so Advocate Health is a large integrated healthcare system that spans 6 states from Wisconsin and Illinois in the Midwest into the Southeast, North Carolina, South Carolina, Georgia, and Alabama. Our hospital at home program has been around now for about 5 years, a little over 5 years. We have in the Charlotte area, we have 10 waivered facilities, including actually it's 11 if you count our pediatric hospital. So we have one of the first pediatric inpatient hospital at home programs in the country. And then we have 2 facilities in the Winston-Salem market associated with Wake Forest University. So for a total of 13 facilities, right now running an average daily census in the 115 to 120 range. We actually are in some ways a bit of a combination of what Steve and Logan described. We have about 85% of our patients are truly inpatient waivered patients, and about 15% of our patients are outpatients, or what we call non-waivered patients, focused on being able to adjust or titrate the needs of the patient beyond just those sort of strict constructs of the CMS waiver. To date, we've cared for over 16,500 patients total since we began our waiver program in March of 2021, and have saved in the last 12 months over 34,000 bed days in our acute care facilities with our hospital at home program. We are currently in the process of scaling our hospital at home program into both the Chicago area as well as into Wisconsin and Georgia.
Nice. Okay. Now let's move on. For the purposes of discussion and for everybody in the audience, we're using hospital home as a general description of the event. Everybody's got a different. Acute care at home is kind of the more popular definition. Hospital home kind of denotes the CMS version, which you have to jump through many hoops in order to get Medicare reimbursement for, and which involves that waiver everybody's talking about, which may or may not continue past December. For the purposes of this conversation, I do want to get into the differences between the two and the idea that what happens if the waiver ends in September? How are these programs going to continue? This is such a vital program. I tend to believe that it will continue, but it might be in a little bit different form if Medicare reimbursement is at least shelved for a while. Now, with that in mind, the first question is value of these programs. How does your program prove? Well, first of all, how do you define ROI, and how are you proving ROI? I'll jump back to Daniel to begin this one.
Yeah, so from our perspective, the purpose for the hospital at home program, beyond just patient care and providing better outcomes for patients in an environment that they prefer to be cared for, and it's really about capacity. So in all of our markets, our hospitals are sitting at 110 to 120% capacity. And so when we really, obviously the hospital at home program began as a result of the COVID pandemic, when again we had more patients than we had space in our brick and mortar hospitals. But with the waning of the pandemic, that situation hasn't really changed. We're in markets where the population is growing and others not. The population may not be growing significantly, but it's aging and becoming sicker. And at the same time, we've also been driving preference. So patients are being preferred to be cared for in our hospitals. So we just don't have enough brick and mortar beds to care for the patients. And so that's really, for us, the prime driver of why we do this from a financial perspective. The other ROI is that we actually get better outcomes for the patients that are clinically appropriate for hospital homes. If you care for these patients in a place they'd rather be, which is at home, which tends to be safer for them because well-documented decreased risk in hospital-acquired complications, so better outcomes for our patients. So I think the financial benefit is all around generating capacity. I think the overall benefit is that on top of better care for our patients.
Okay, Logan, same question. What's the ROI for your program, and how are you proving it?
Yeah, I won't retread a lot of the ground that Dan just stated. We align almost exactly with a lot of the tenets of why we do the program, not only from a capacity and utilization kind of level setting approach, but also just knowing the improvement in the outcomes for the patient. I think a lot of times this conversation comes back to whether we like it or not, it is the dollars and cents of it. I know that often gets a lot of people's attention. Like I mentioned in my intro, we began our exercise with our value-based lives. We have since expanded it to all Medicare patients, at least in our market. When those patients are admitted, traditionally those are loss-leading admissions. So there is certainly a overlap of the Venn diagram. If you can right-size a resource for the patient's acuity, you also right-size the financial picture for our facilities and our health system. I think a lot of times people think these things are mutually exclusive. It's somewhat bad to think about taking care of a patient differently because of the financial implications. I don't think that that's true at all. Our exercises and part of our success has been to bring our CFO group and financial analyst in at the ground floor of this exercise. A lot of times the math is not known. There is not a lot of being able to carbon copy this from different systems because each of our ecosystems financially are very different. So you have to build really your financial story with these partners and iteratively work it and improve it. And where we're at now with these two populations with the products that we use, and it depends on the product, but with these value-based lives and the Medicare lives, and when we factor in a common bed replacement, looking at all of the payers in our market, not just the ideal payers that are coming back into that bed, we are seeing in excess of an 8 times ROI with one of the products and a 3x ROI on the other. So we're very bullish about where this is going. I think the next horizon that we're all waiting to see where the shoe drops is what happens with Medicaid, with the federal cuts in that may be looming, and what that may mean for what we have to do to right size kind of the venue of care for patients when it's safe and appropriate, so that it is for the financial kind of austerity of our systems.
Yeah, I like what you said in that a lot of these programs, you have to, it's not a cookie cutter approach. A hospital home program is pretty much ideal to the specific health system or hospital that's using it. There's a lot of room for maneuverability around here. Now, Stephen, you've got one of the older programs, the hospital home programs. It's been around for quite a while, and I know Mass General Brigham has published results of some of the early hospital home efforts. What does ROI mean to you? And are you seeing anything different in ROI? It's something you didn't expect.
No, I mean, we see the same things that Logan and Dan have talked about and place a premium on. We value our program for exactly the same reasons. To your point, Mass General Brigham started conducting care in the home in this way back in 2017. And we did it under exactly the same auspices of demonstrating value-based care benefits for taking care of complex patients at home rather than in the brick and mortar hospital, and looking to study and evaluate what outcomes could be through this type of care model, recognizing that there's a growing and aging population with a growing list of comorbidities that need care, and that we don't have the resources either already existing or will to be able to care for them within brick and mortar hospitals. And so we took the benefits that we saw through randomized controlled trials that we conducted out of our Brigham and Women's program, and then married that with best elements of what we had out of our Mass General program, which was running the value-based care demonstration. And that's how we built our integrated operating model that we then scaled across the enterprise in Greater Boston. And what we see today, we haven't put out new RCTs because what we see in our observed experience reflects what we published in our early RCTs, that there's lower rates of readmissions, there's lower rates of complications, that the patient experience is really off the charts. I mean, our net promoter score is in the 90s consistently. And achieving that within healthcare is pretty phenomenal. So being able to give patients a safer alternative to how to receive their care in a way that they find more satisfactory than what they would receive within the brick and mortar hospital, to say nothing of all the financial benefits that also come with it, it's really a no-brainer from a strategy perspective for where we should invest continued growth.
Okay. Next question. It's a good one. And I'm going to start with you, Logan, because you're the kind of the newer entrant here, having joined the hospital home community more recently. How do you get support from the C-suite, and how do you get support from your clinicians to launch a program like this?
Yeah, this is actually an interesting question, especially from the vantage point that I look at it now a year and some change on. So I would say within the kind of the cohort of management, I would even say, and I'm sure this has been my colleagues' experience as well, is that there are different camps and factions there. My earliest champion of this was a system VP and a chief operating officer who wanted us to solve for an overutilization of our flagship facility for low acuity observation admissions. And so I had my COO literally leading the charge and telling me and my team to dream big, be bold, move fast. Alongside of that was, and I mentioned that part of the success is you've got to get your finance folks on side. That also comes with the transparency of the story is that tribe within management has been a slower adopter of the concept. And I think that we all understand that these folks' tendencies for good reasons is to be very conservative and cost conscious, because they have to make sure that the entire ship floats day to day. So, you have to start somewhere. We certainly having a champion within your C-suite is, I think, of the utmost importance. Ideally, everybody is aligned. I think realistically, that is not all the time the scenario, and you just have to have a foothold, start somewhere, and start to do the work and iteratively display what your value proposition is. And I would encourage people who are doing this or thinking about rebooting this is don't boil the ocean all at once. Really focus on a subset of patients, maybe a subset of payers, and work the opportunity from that angle. Clinicians, at least in my health system, we're so hungry to do things differently. I think especially coming out of the COVID era, where all of us were just worked to an extreme we never understood, is that I think people were more cognizant of what is the yield of their work. And I think it's safe to say that clinicians were tired of this hamster wheel of doing the same thing and seeing it literally go to dust. And so when I was able to show them that we had a trusted method and a trusted partner in the place to transition patients' care to, all I had to do was show them a few times. And then the rumor mill happened in a good way. They started to carry the message for me. And while these things are hardwired and it really take a lot of the guesswork about who is eligible and all of that away from my clinicians and really makes it easy for them, I still get the value and the push that they generate in that word of mouth that they spread, because it is something that they can trust. So I think that I would leave you all with my thought there is that it was an equal part of satiating that hunger, as well as showing them that there is a trusted avenue, and the adoption with them has been easy. And in fact, there's such a fervor to do more of this that my management, especially my finance team, gets actually a little bit nervous, because they're afraid that it would be something that would consume a lot of dollars really quickly. And so we just want to be tempered with how we feed that appetite. But I think it's a good appetite to have.
There is some criticism for hospital at home, and one of the reasons is that it is complex and that it does consume a lot of dollars. But Stephen, how do you deal with that skepticism? How do you get buy-in if there are some that are skeptical of the ability of an RO of a hospital home program to be sustained?
Well, I mean, we start with showing the results. The proof's in the pudding, so to say, and the outcomes and the patient experience and the patient stories speak for themselves. And there's really no denying that. When you then tie that to the fact that you didn't spend $6 million to create a new physical bed in a downtown hospital in an urban environment in particular, then that starts to speak for itself as well. And then the other thing too, there's a common criticism around, well, you're taking the workforce that we need within the brick and mortar hospital. The reality is, if you were going to expand beds in a physical environment, you would need added workforce as well to be able to create those added beds. And so we can either invest in continued brick and mortar buildings and keep doing exactly the same things as we've always done, and we will fill them, and then we'll continue to have folks lining our hallways waiting to get in. Or we could take a new approach to things and demonstrate the better outcomes, demonstrate all of the phenomenal experience benefits, expand our overall capacity, and actually retain clinicians within the workforce by broadening out their portfolio experience and enhancing that patient connection that drove them into medicine in the first place. And that's exactly what we've seen, is that we've retained more clinicians in the workforce and kept them from burning out, especially on the far end of COVID, by diversifying their clinical portfolios and giving them the experience of delivering home hospital care. Because there's nothing like going into somebody's living room, sitting down, looking around and seeing all the photos of their loved ones, the life that they are looking to experience in a healthy way once they get through their acute phase of their illness, and helping them to achieve that. And so there's a lot of change management that's caught up in all of this. I mean, this is not how any of us went to school to learn how to deliver care. And so you're going to face your skepticism. It is a hill to climb for sure, but I think that we've got more than enough proof points and experience now behind us to be able to tell our story and continue to advocate for continued growth of these services across the country.
Yeah. I like that this is seen as a better way of delivering care. I mean, so much of the promise of AI, of virtual nursing, of digital health is that you're getting doctors off the computers, away from the laptops and in front of the patients again. There's a lot of good to be said for that. Daniel, same question. How do you deal with the change management, but also getting buy-in for a program like this?
So I think from a management perspective, you have to be able to tell a story. You have to be able to tell the full story, which is the clinical examples and the individual patient stories. But you have to be able to accurately outline the benefits of creating this capacity in a very low capital cost environment. So you have to be able to tell the story. You also have to show the results. And I think that we had the benefit of being around through the COVID pandemic, of being able to go to senior leadership and say, look, this is what we've done. These are the kind of patients we've been able to care for. These are the results we've been able to get. We are very fortunate to have a CEO in Gene Woods, who is a complete believer in hospital at home. So from the top down, it is a priority of our system. It is being built into the strategy of how we're going to care for the population of people that we are responsible for. The middle layers sometimes are a little more challenging because they're the ones that actually have the financial accountability within a certain facility or a certain market. I still think then you have to be very you have to be very clear and be able to tell the story very concisely. Both and in that group, really, it's about the finance part of it. You've got to be able to explain how this is not going to be any more expensive than caring for patients in a hospital, brick and mortar hospital environment. To do that, you really have to understand your costs, and you've got to have a team that can provide you the data that you can show the hospital leaders that show this is how much it costs for us to deliver care, apples to apples, oranges to oranges, in a brick and mortar facility versus hospital at home. When they see that, and you can show that it's at least no more expensive, and we can create capacity that really doesn't require much capital, they really start to see that, and I think the wheels start to turn. You really have to get that senior market and facility leadership buy-in that you already have it from the C-suite. I think from a clinician perspective, you also have to start with a story, and you've got to be able to explain your outcomes and how you are able to care for sick patients. I think you also have to make it easy for them. If you make it challenging, if they have to remember, and this is where I think Logan and I may have a slightly different opinion, we are payer agnostic and we are disease agnostic or condition agnostic. It's all about the clinical acuity of the patient. We don't want anybody to worry about what payer the patient has and so forth. We want to make it easy. You think the patient's clinically appropriate for hospital at home, you have any idea that it might be, send us a referral, we'll vet the patient, and we'll take the ball and run with it from there. The bedside nurse isn't going to be burdened with much. The attending physician who has the patient is not going to be burdened with much. We'll take the ball and we'll get the patient home. And I think that's been a big game changer for people to not have to worry about, okay, is this a patient that would be eligible or not eligible? And that gets easier as you do get some scale. But from the very beginning, that's the approach that we have taken. We've also had hospitalists in particular that have rotated through, even though we have a dedicated hospitalist team. We've had hospitalists that work in the brick and mortar that moonlight with us, and they have been some of our best advocates because they actually come and do the work, and then they go back to the brick and mortar hospital. They're able to tell the story and reassure. The last piece I'll say is for all of these groups is you have to continually go back and re-educate. You just have to you can't just do it once and a year later expect everybody to remember what you told them. It's an ongoing relationship that you build with both a virtual and a physical presence within the facility, from navigators and other team members that are continually reminding the team, this is a strategy that's here to help take care of your patients, get people out of the hallway, get people out of boarding in the emergency department and so forth. So I think you have to. I think it takes each one of those elements to successfully scale.
Yeah. That condition agnostic approach is interesting because there are so many programs that, to start with, they focus on certain populations, certain chronic conditions. Mass General Brigham, you've done one with, I believe, with veterans. Different groups of physicians or patients with specific medical conditions that you qualify as candidates for patients for hospital home. So it's interesting to hear that instead of looking at the condition, you look at whether the patient himself or herself is a good candidate. I wonder if this is how these programs will evolve.
The fewer roadblocks you place, the more patients you're going to get. And certainly there are certain post-op patients and things that we may not have at some point in time, the wound team may not be available. So you may not be able to take them every single time, or we had to develop a wound team to be able to take certain patients. But instead of saying we're only going to do heart failure, or we're only going to do pneumonia, or whatever the case may be, make sure that your care teams have the tools to take care of as broad a clinical spectrum as possible.
please.
I would echo that. Just that's something we learned very early on, like literally in the first few weeks, but because originally we said it was going to be diagnosis kind of, well, 1 through 10 is what we entertain. And what we found is that just blunted our yield. It was another decision node that people had to manage, and then they just didn't. So I can't speak for everybody else's, but it sounds like that we've gone a similar trajectory in that we've said, hey, just send us what you think in your discretion is appropriate, and we'll take it from there. We'll vet it and we'll let you know. And then what's kind of interesting about like what happens as a consequence of that is then you can actually then specialize into more honed disease, specialized care, service line kind of care models and things like that. I'd agree completely with what just Dan said. So I think we're actually closer than further apart.
I think we're completely aligned there. Yeah, absolutely.
Here's a question here that I like because a lot of hospital home, a lot of the idea behind hospital home began with the idea of taking hospital care and putting it into the home. So a lot of these programs were devised from the hospital to the home, and there have been some concerns about, is the home ready? Is the patient and the patient's family ready for this type of care in the home? So I wanted to know from you. And I'm going to start with Stephen on this. What do you do? How do you work with patients and their family to make sure they're ready for a program like this in their home?
Yeah, I mean, it's much like anything that you do in healthcare when introducing an idea or a treatment pathway to a patient. It's all about informed consent. You have to be able to educate them on the model, tell them what it's going to mean for them. Ensure that it's not just the patient who understands it, but that the others who are going to be impacted are understanding it as well. So who else lives there? Is there somebody who's a primary caregiver day to day to the patient in the outpatient world that you need to make sure understands you're not shifting the burden onto them when they leave the hospital and go into the home? That your care team is going to be available 24 hours a day, that you're going to be in the home multiple times a day for whatever might arise within 30 minutes if operating under the waiver. Once you bridge that gap and educate them about what's going on, then the majority of the time you're going to get them to yes, assuming that they comply with all the other safety components that are necessary to ensure that your staff is safe as well. Are they agreeing to keep firearms locked up when there's staff in the home? Will they keep pets secured when staff are in the home? Those kinds of things. And so once you walk through that informed consent process, you can get them there in understanding it. The important thing is you're not looking to recreate the hospital in the home environment. You're looking to bring services from the hospital to the home environment, and that you're adapting them accordingly. And being able to operate within that mindset is really important, because honestly, a lot of patients are afraid that what you're going to do is turn their living room into a hospital. And so informing them that that's not the case, that you're really looking to be as minimally intrusive as possible, and that you're really being invited in as a guest into their home, then you'll find that more patients are ready than you think.
Now, conversely, is there a lot of preparation needed to get to prepare the caregivers, the doctors and nurses that go into the home? How much work goes into getting them ready to go into the home environment?
It takes a distinct set of tools.
Yeah,
go ahead, Dan. You jump in, please.
Yeah, I was going to say, I think it does require a significant amount of training for any of the teams going into the home to understand the unique nature of care in the home. Because most of the nurses and paramedics that are doing this, paramedics come out of the 911 system, and it's a very different approach, right? They're in and out as quickly as they can. Nurses, most of the nurses we get are actually inpatient nurses, so they're ED or ICU nurses. They're not home health nurses, so they don't have that corporate knowledge of care in the home that home health nurses have. I think it's connecting those team members to those with experience and making sure that you go through an incredibly rigorous process to make sure that they have all of the competencies that they need to be able to provide care in the home. I think and that you've done everything you can to help guarantee their safety. You have panic buttons and code words and all of the things that you can do to make sure that you can summon help when you need to, geo tracking so that we know where their vehicles are, appropriate dispatch and things. So I do think it's incredibly important to have that specialized training, that you can't just take a nurse out of the ICU and send them into somebody's home and expect they can put an IV in a rock, right? I mean, they can do all the things they need to do clinically, but you have to, all the things Steve was talking about, pets and firearms, and also preparing them to see some very austere environments. Like many of the homes we go into, most of us would not consider livable, but that's where we go. And our teams have got to be prepared for that. Paramedics, they're not scared of anything. They're ready to go. It's more getting them to slow down and take that more nursing approach of being able to spend the time they need with the patient and getting used to developing relationships. And that's really why a lot of them want to do it, because they're kind of burned out from the 911 group. But anyway, it's just getting them to understand what's different about the home care environment as opposed to the brick and mortar environment.
Okay, Logan, same question. How do you prepare? Well, how do you prepare the patients for this type of environment coming into the home, and your providers for going into the home?
Yeah, I think it depends on the service that you're seeking to render. So I've seen some of the work that my colleagues have presented, and we all have a diverse portfolio or suite of services that we offer. So sometimes the lift is different based on what service that you're doing. To be a little bit more clear about that is saying that if I want to take somebody out of my emergency room who is safe and appropriate still to come into this service, they are at kind of a maybe almost a nadir of their acuity, not a nadir, but a peak of their acuity that requires a different tempo, a different kind of resource allocation. And so you really got to right size not only the expectation of the patient, the caregiver, and the team for what is about to come in that context. But like you always have to assess for what the mission is at hand. Whereas if we're upstream from a clinic location or even downstream, and we're really wrapping up a hospital stay, and this is an add-on, I think kind of the profile of services and the intensity thereof and that tempo and cadence is a little bit different. So there's that part that's considered of it. I think kind of like what is the juiciest part of this question is the caregivers. And I really liked what Dan was expanding on is making sure that your team in the home is acquainted with what home care looks like different than what traditional brick and mortar care is. With our model, we utilize the services of a partner, Maya Laurel, and we trust that, but we did a lot of vetting of that, including ride-alongs and going and seeing and really understanding how, as we say in Louisiana, that gumbo is made. What is their competencies of their workforce, how they all interact, what's the interdependency of different team members. And what that changes for us on the provider organizational side of things is that we don't have to necessarily assume all that logistic burden. It is a necessary burden, but the workforce development and all of those things that are really important to generating the care and the care outcomes we went a different route and brought in a partner, a right-sized partner for our size of operation to assume a lot of that. And what's also good about that partnership is they're very responsive to our feedback for when things need to look different, be different. And so we're constantly at an interface with one another to evolve that patient care experience and anything that it may need, either from the clinical aspect or some of the kind of the more soft touch elements.
Nice. Okay. I just want to point out we've reached right past the half-hour mark of this presentation, as I knew we would. A reminder to those in the audience, if you're interested in asking a question, please use that Q&A widget. We either will have a Q&A session at the end of this hour, or we'll just keep talking. That's fine with me too. Let's see. Okay, we've talked a little bit about this, but I do want to get into more detail because this will be a bigger issue as the summer moves on, and we get closer to that September 30th deadline that is looming for the CMS waiver. How are your hospital at home programs sustained? And I know this is a financial issue. How the understanding that they probably don't make money, but they do save money. So how do you sustain them? How important are those waivers to sustainability? And what's going to happen for you if CMS decides to go another route? Start with Daniel on this one.
Yeah, I mean, I think the waiver is important for a sign of legitimacy, but it's not essential for overall success or failure of the program. I think that it says that CMS values the inpatient level care in the patient's home, and they're willing to pay the DRG for it. We are dedicated to continuing our hospital at home program with or without a waiver. We'll have to make some pivots. I mean, the reality is the majority of our patients come off the floor. We've already captured the DRG. It's really, really difficult, even in a large program at scale, to pull a significant number of patients directly from the emergency department. You can do it. It's just, it does create more expense. You have to have more staffing because you got to go later in the night or even truly be able to move patients home 24 hours a day, which may or may not be that patient friendly. So I think that what we would do is likely, again, if capacity, well, either one, if capacity is your primary driver and you need to create space in your hospitals for people who absolutely have to be there, then you're going to have to do something like this, right? I think if you're deep in the value world, like a Kaiser, where you're a payvider, right, then this makes sense then too, right? Because you may be able to do this in a less expensive way to care for the population of patients. So if you're either deep in value and you can control the expenses in that 30-day window around a hospitalization, you can make sense of a hospital home program without the CMS waiver. If you are at 120% capacity and you don't want to spend, as Stephen said, $6 million a bed to build a new hospital, then a hospital home program that facilitates going from transfer and disposition to a home unit, which is really what hospital at home is, to a facilitated early discharge with high acuity level, you can do the same work, right? You just would have to pivot in how you do the billing side of it, and you would have to pivot with the documentation and so forth. But I think we're dedicated to doing this with or without the waiver. I think the waiver is incredibly important. I don't want anyone to think that I'm saying it's not important, but it's not essential for the success of the strategy.
Nice, yeah. All right, Stephen, do you see issues with sustainability?
Taking the same perspective as Dan, I think that's how many others in this space are going to transition. One of the key issues within the home-based care delivery space is that we all, from a clinical and experience perspective, see the benefits and the opportunity of truly building a seamless care continuum in the home-based environment. But our existing fee-for-service structure is not built that way. And so hospitals and health systems are going to have to, in order to tap into that prospect and that opportunity, they're going to have to shift their approach to looking at things. Instead of being a direct fee in exchange for an expense, that they're really looking at the offsets of what are we garnering that's not necessarily captured explicitly within a P&L. And that's going to be based off of incremental margin of backfill cases that are coming into the acute hospitals because of an increased rate of turnover and optimization of your ODE by using these early facilitated discharges. And that's all not captured in a clean, simple P&L at the end of every month or at the end of every quarter. And so there is a need to reassess what the calculus looks like for valuing these programs, back to the earlier point. But that's how this is going to persist and continue to grow beyond the waiver, because the waiver, again, extremely important, completely agree with Dan, but it's limited to a finite set of patient parameters. And there's a lot of added opportunity that's not supported by those parameters that hospitals and health systems could tap into.
Yeah. I think you're finding, I mean, there are some 400, maybe close to 400, I forget what the last number was, hospitals and health systems that are following the CMS model. But there are many others out there that are trying their own ideas. It's not a hospital at home, it's acute care at home. It's something different, but similar, because the need is there. And and value will be measured in different ways. Logan, same question. How do you see sustainability with or without the waiver?
Well, Stephen just took me to church. I was basically saying amen over here with everything he just said. So, look, our pretense is different in so much that we organizationally had, and this actually predates my involvement, a bad taste in our mouth with our previous forays with the waivers, in so much that they just did not offer malleability that worked in the ethos of our care environment, and also kind of the regulatory kind of landscape of our state. And it was also because of some of the requirements, it was seen as not a value add, but as a value drag. And that's why we stepped away from it, and that was pre-COVID. So when we came back to this conversation, picking up on just what you and others said, it was with the ideas that there's something here. We've obviously got to do this. We've got to redefine how we're delivering care just so that we have space to take care of everyone, or the ones that need to be here. And with that, that's where we were like, well certainly there is the there is there of taking care of patients in their home settings. We just have to find the way to do it differently. And so I would agree. I'm not saying I don't think that there's value in the waivers. I think if the waivers are going to make sense, they've got to be a more wholesale approach across many of the diagnoses that we care for. I think one of the things you've heard us say is like, you've got to be really flexible with your clinical inventory of what you can care for these things to be successful. And I think the waivers have to be able to match that flexibility that's needed to be able to appropriately and timely transition patients' care from a traditional brick and mortar location to a home setting. Similarly, I think that it's got to be malleable with the idea that we have a multitude of ecosystems across the healthcare ecosystems across the United States, and it can't just be a little bit of a one-size-fits-all type of philosophy. So for those reasons, Ochsner for now has just not used the waiver as the cornerstone. But I would tell you, if it came around and evolved to something that worked for us, yes, we would embrace it. And certainly it is the endorsement of the principal regulatory, entity of the United States that this is even more so a path worth blazing down.
Oh, there will be pressure certainly on CMS to take a closer look at that waiver and maybe amend the way hospital home is supported in the future. I think there's
the other thing I would add, just as a tack on into what Stephen was saying, is not only do you have to do that work to do the calculus that is a little bit unseen in a lot of the ways that we do the numbers, but once you've got that horizon and you really achieve the scale of what we got to do, I'd say maybe parallel or maybe more so than hammering CMS to make this work more for us, that's where I think you put the grind and the muscle into going to your payers and playing to their book, which is we can get care at a lower cost, and we also know that we're going to get care oftentimes with better outcomes that are much more patient centered, that everybody is singing the song about, that this is better, patient and providers alike. All the while, you kind of Jedi mind trick, if you will, your payers. So you say, we can do all this at a lower cost point. And I think that is the horizon that we need to take all of this groundswell of effort and innovation. That's where we should go next, and really, played to their songbook.
And I agree. I think one of the things I think one of the things that we don't drive home enough is that this is not just equivalent care, but it's better care. And that payers and systems owe it to their patients to explore this in whatever flavor works for them, but to realize that taking care of these patients in this slice of acuity, it's better for them to be at home, and it's us as a team between payers and regulatory bodies and healthcare systems to work together to find a way to value it in a way that makes it more sustainable.
Okay, I'm going to pose that same question to Stephen. Do you get other payers involved in the conversation, and how do you do it?
I think you have to. The trouble is, at least in Massachusetts right now, all of our commercial contracts, commercial plans, they have to comply with the conditions of participation. And so if CMS doesn't extend the waiver, then commercial plans for this type of service don't work. So then you get into a state of, well, let's be innovative around the reimbursement structure for how we want to bundle these services together and deliver them on a new platform and encounter structure. That's a very different and much more difficult conversation to have. And so that's where I think the pressure really does come back on with Congress and authorizing extension, because this isn't something that CMS can just independently decide to do. It requires congressional action at this point. And so I hope you're right. I hope that there's tremendous pressure being felt in DC about the inclusion. I'm extremely optimistic about it. But I think that's going to be the much faster route than trying to go to commercial payers and ask them to be innovative with us. When it's already been such an uphill climb to get them to buy into the inpatient reimbursement framework for this care model in the first place.
Yeah, therein lies the challenge. Well, we're closing in on 10 minutes left in the hour, and I do have a very good question. One of the questions that has come in the Q&A that I wanted to get to, and it kind of goes back to some of the conversation we had earlier about how in-person care is delivered in home. I mean, we could certainly talk about the technology, the virtual care, telehealth, RPM methods used as well. That would give us another couple hours of conversation, I'm sure. But this one here, and I know a couple of you had mentioned how you're delivering care. Do you work with home health agencies? Do you have community paramedicine involved? You know, how is that care delivered to the home in person? And what are the benefits of the different types of arrangements and that you have? I'm going to start with you, Stephen, on this. How does Mass General Brigham actually put people in the home?
So we have distinct teams predominantly that support home care, traditional home health services for those 30 to 60 day episodes for homebound status individuals. Compared to what we're delivering on the home hospital side, where you're in the home 2, 3, sometimes more times a day, every day for the duration of their inpatient episode, which for us is typically a 4.5 day length of stay. We have some contracted services that overlap between the two, like on the therapy side, for example, or with social work services, for example. But for the most part, the clinicians are very distinct because they have a distinct set of skills that are needed to be able to support the phase of acuity. That said, it does lend to the opportunity of embracing the care continuum that could exist within the home, where we discharge patients from our home hospital into our home care service. And as we walk out the door, the home care service walks in. But that's not the majority of our patients who are qualifying under that homebound episode. So yeah, what we found is just that they're different phases of care, they're different episodes, and they require different skill sets accordingly.
Okay. Now, Logan, I believe you contract for the home health part.
Well, our hospital at home equivalent, though it is not hospital at home by the definition, acute care at home is a partnership with My Laurel, which is a growing kind of entity in the home care space. We have a pretty long relationship with them, predating even COVID, and with their predecessor that was called Ready. And so we're a investor in it, a very minor investor, but we're a developmental partner. And I think that's also what has kind of informed that we have really been able to get something that works for us in the Ochsner vision. And, you know, I also think that this is paying dividends to other health systems that are interested in a similar type of product that is near the idea of hospital at home, but also decidedly different, and that it sidesteps a lot of the traditional elements, cumbersomeness, if you will, of the waiver. I will also say is, again, we're a new entrant in this space operating at scale. And so when I, you know, either hear or listening to Stephen or Dan's presentations in other forums, I'm really impressed, and I look to what they have developed really as a roadmap for what we've got to do. Right now, organizationally, one of the biggest issues that we've got ahead of us is that we've got to develop connected care amongst all of these different shops. So some of those are going to be with strategic partnerships like MyLaurel. Some of those things exist, and we just got to more purposely scale under our own shield and shingle. And there's all different types of derivatives in that. And then there's also some pretty good stuff that we have that our payers resource. But not only is, I think, the challenge in this activity of developing kind of more connected care across the care continuum for one patient, it's also developing kind of a new ecosystem of all of these connected resources and tools that comes into a hub or some type of hive-mindedness or sentience that helps to sort through not only what's appropriate for that patient, but also to generate the awareness that sometimes when multiple things are in the place at once. So yeah, there's a multitude of opportunities that exist, but you know, it's not lost on me that one of the things that we've got to do as a newcomer in this space is to develop the connectedness between these different tools, whether they are ours that we have built or that we contract out.
And okay, and Daniel, you're in-house with your home visiting group, right?
Yes. So the majority of the care that's delivered physically in the home is by our paramedicine program, our mobile integrated health, that is internal, it's employed. We do have also some internal therapy resources that go into the home. We have wound nurses, physical therapists, occupational therapists. Most of what they do is virtual, but we do have a team that goes into the home when it's clinically appropriate for the patients. But the paramedics really are the hand, ears, eyes, you know, boots on the ground in the home. I will build on something that Logan said. I think one of the things that we've been doing over the last really 2 years when we aligned our hospital at home program with this umbrella of continuing health, which is our really in-home and community-based care continuum, is attaching hospital home along that spectrum of care. So just like Stephen said, home health also falls under that umbrella. Very different acuity, very different approach. But we can seamlessly hand patients from the hospital at home team. We now have this outpatient arm that we call Flex. So we can be flexible about the resources. So we could go from inpatient hospital at home to this outpatient unit for those clinically appropriate. We can then hand off to home health if needed. We also have transition services, which is our transition clinics that have a heavy in the home presence. And then I'll tie it all the way back to primary care, virtual primary care, and others. So we've been trying to become more and more intentional about building those bridges because, as Logan was saying, it's incredibly important for this to be seamless for the patient and also seamless for that care, for the care team, for the physicians that are helping to direct and the APPs that are helping to direct our patients' care. We want to create the easy button that basically says, my patients at home, they need a level of care. I'm not even sure what the level of care they need is, but help me figure that out and which team needs to be there and move the patient then along that continuum. It's, you know, we're not there yet, but we are getting well down the road of pulling all those teams and strategies together to make it a coherent process for the patients and for our clinicians.
Yes, yeah, nice. Okay, we only got like a minute or two left. I just want to get one last question in to finish off this program. Of course, we could go on forever with this. Where do you see the biggest innovation coming in hospital home in the near future? You know, what's the next big thing for this type of program, of philosophy? Daniel, start with you on this one.
Quickly improving RPM technology. more ambient monitoring, more advanced patch wearables. So I think that's going to be incredibly important, using AI to help sift through some of that data. And then also but patient acquisition and logistics. So developing a less human-driven patient acquisition and logistics process, and then building a better RPM platform for us to be able to better see into the world of our patients.
Nice. Okay. Logan, same question.
Absolutely agree. AI informatics supports for patient acquisition. Couldn't agree more there. And then also the evolution of RPM.
Okay. And Steven?
I'll say the other enabling technologies, making things more portable and modular in nature so that we can add on to one another and shift more care capabilities out of the brick and mortar environment and into the home.
Yeah. I like the mention of RPM. There's certainly a lot there. A lot of innovative ideas there that you're seeing at CES and some of the other events, and a really good way of extending care into the home if you can master the technology. Okay, that's all the time we have for questions. In closing, please note that our next Winning Edge program on July 8th, it's almost July, will cover the Winning Edge for advancing nursing advocacy and legislation. A live clickable link will appear at the close of this program for this event, taking you to our registration for that event. So you can click on to register for that event. You also will be seeing a continuing coverage of this event this week, culminating in the YouTube version that we're doing now. That'll be posted on Friday. Remember to follow along all week for this continued coverage for improving your hospital home strategy on our website, healthleadersmedia.com. I want to thank our three panelists here today for an excellent discussion. This was really good. As I said, we could continue on a topic that I think a lot of hospitals and health systems are very interested in. If they're not doing it now, they're really thinking about it. And finally, thank you to those of you in the audience for participating. We hope you enjoyed today's program and look forward to seeing you again during future Winning Edge programs and other Health Leaders events. Thank you very much.